welcome to Infection Control Matters. So usually it's Brett and Martin who are the ones asking questions, but today we've turned the tables, and I'm Trish Peel. I'm an infectious diseases clinical trialist, and we're going to be discussing the HAPPEN trial that was recently published in Lancet Infectious Diseases. And I'm thrilled to be joined by a special co-host, Sally Havers, president of ASIPSI.
Thanks, Trish. It's great to be here. And I'd just like to also introduce, so we've got Brett Mitchell and Martin Kiernan, who you'd be very familiar with. And we're also joined by Nicole White, who's a statistician on the HAPPEN trial as well. So thanks for coming along, Nicole. ASIPSI was a proud partner in this study, but we wanted to put the researchers in the hot seat. And so, Brett, I'm going to start off with you, of course. You've called non-ventilator associated healthcare-associated pneumonia, or NV-HAP, the forgotten infection. And anyone who spent more than probably 2 minutes speaking with you knows how passionate you are about pneumonia in particular. Why do you feel it was time to step out of the host chair and, I guess, do a bit of research and lead a trial of this scale? And why NV-HAP, or this particular infection?
Thanks, Sally. Thanks, Trish. It is weird being on this side of the fence. It's an interesting one. So Martin and I, along with a few others, for many years have been going to conferences and
many years,
and we've been hearing NV-HAP, or HAP, or pneumonia, hospital-acquired pneumonia, being the most common infection. And it keeps coming up in point prevalence studies from the ECDC and the one in CDC, and lo and behold, in Australia it was common too. And what we have seen in the past is a lot of strategies and initiatives for other types of infections, but not really anything for non-ventilator associated hospital-acquired pneumonia. In more recent times, stuff for VAP, but not much for NV-HAP. And I guess, we kept asking. I remember, like, Martin, you got up at conferences, and I have, and we said, so what are we going to do with this data that keeps telling us that HAP is a problem? And no one ever had an answer. And I think it was always put in the too hard basket.
Yeah, we're working on it. I think we've told twice at ECMID, or then ECMID Global.
Yeah. And so we got together, and Nicole has been on this journey as well for some time. And I think I can't remember exactly how many grant applications we've tried, but I'm going to say it was probably at least half a dozen, probably closer to double figures, before we managed to get funding for an NV-HAP prevention trial. And we kind of thought that this is one of the low-hanging fruits in IPC. There's lots of things that are common and lots of things we don't know. And sometimes we try and tackle complicated things, and that's great. But sometimes, whilst NV-HAP is really hard to study, we thought we just needed to give it a crack. So Nicole and Phil Russo and Alan Cheng and others have been on this path for a long time. I've dragged them along, and Martin's been part of that too, of course.
I remember talking with you, Brett, at the ECMID Global when you were about to present it, and I was absolutely horrified when you told me the stats on community teeth brushing, let alone oral care in hospitals. It's such a fabulously simple trial and question and intervention. And I guess, why do you think it's taken so long for something so simple to be tested in a trial?
Well, I think I might leave that for Martin and Nicole to comment on too, but I think that one of the hardest things has actually been designing a trial, because there are so many confounders to many things in IPC. So that's one side of it. Whilst it's common, this infection is still relatively uncommon in the context of, powering a study appropriately. And determining the outcome is actually the tricky part and the really time-consuming part of a trial for this one. And so you really needed, I think, to have the funding to be able to prospectively look at pneumonia cases. So I think probably there have been some of the major things. But well, I don't know whether Martin and Nicole have got more.
Yeah, I mean, for me, HAP has always been an itch I couldn't scratch. And like you, I've seen studies showing HAP as the number one infection. I mean, for years, I've been around in IPC for a long time, and every 5 years of the UK, we do a point prevalence study. And for years, it was UTI, and then 2004, it was C. diff, because we had a major countrywide problem at that time. And then after that, HAP took over. 2011, HAP is the number one. Now, 80% of the pneumonias were not ventilator associated. 2016, it's about a third of all infections. But as you say, it's relatively uncommon in your everyday practice, but we don't do any surveillance. So no surveillance equals no data equals no problem. And that was the issue. But what I did start to see was we started to do root cause analysis for the large numbers of C. diffs we were having. And you say, okay, were the antibiotics necessary? And it's like, yes, we had to give the antibiotics because the patient had pneumonia. Okay, that's fine. The C. diff's unpreventable. But what we didn't do very well was go, well, actually, why have they got pneumonia? And so tracking it back, was the pneumonia preventable? So they wouldn't have needed the antibiotics. So, but I think the large problem is there's no data. And you do a prevalence study every 5 years and you go, oh, that's very interesting. Don't do any action. And what a shock. 5 years later, you get the same result. So therefore, I should think that's probably why you struggle to get the funding, because you weren't able to demonstrate the direct impact. But anyway, thankfully now we have. And the other issue is no country had a guideline on HAP prevention because there weren't enough studies to write a guideline on. You know, you've been involved in systematic reviews and found almost no studies of a high quality to be able to say we can now put something in a guideline. And hopefully this has started to turn that tide.
I think too, speaking as a statistician, Brett hit the nail on the head before in terms of the design. It's just really complicated to work out how do you design the rollout of this type of intervention in a way that it can be rigorously evaluated. So whenever we think of clinical trials, we always think of patient-level randomization as the gold standard. But for an intervention such as toothbrushing, it's impossible to conceal who's receiving the intervention and who isn't. Which sort of took us down the path of doing a cluster randomized trial as sort of the best design within practical constraints.
So that leads nicely to our next question, actually, Nicole. For those of us who might not be familiar with a stepped wedge design, you sort of talked a little bit about the difficulties around, doing a patient level randomization. Can you just give us a bit more information about how a stepped wedge design works for people who might not be familiar, and how many wards were involved and how that works in terms of the statistics and being able to look at the intervention?
Sure. So a stepped wedge design belongs to a broader family known as cluster randomized designs. So when we talk about the term cluster, it's an approach to randomization that instead of allocating individual patients to receive an intervention or not, we're randomizing groups of patients to receive the intervention. So the groups of patients could be a hospital ward all at once being exposed to the intervention, or even an entire hospital being exposed to an intervention. So where the step wedge element comes in is in the HAPPEN trial, we enrolled 3 hospitals, and within each of those hospitals, we enrolled 3 wards. So the step wedge involves the randomization of each of those individual wards to receive the intervention, but at different times along the way. So if you think about it in terms of visuals, we have a design that literally looks like a staircase where we have different wards crossing over from usual care to the HAPPEN intervention at different points in time. So there's lots of benefits to step wedge trials that people may be aware of. I guess sort of the most common one in terms of the pragmatic trial approach, we're able to manage the logistics of rolling out this intervention to large numbers of patients at a time. So by having individual wards or hospitals transition at different points, we're able to logistically plan out how this intervention will be rolled out to one cluster at a time, typically with the same person to maintain consistency. The other key benefit that some people may be aware of is it allows each hospital to act as its own control. So because different hospitals might have different IPC strategies in place, it's inevitable that different hospitals or even different wards have different baseline rates of NV-HAP. So by having sort of that step wedge cluster framework, we're allowing each hospital to improve on itself. And then in terms of the analytics itself, we're looking at what's the typical change within a hospital attributed to the infection. And as I said before, in this particular case, because we're switching everyone over at once, we don't need to blind who's receiving a toothbrush and who isn't. So just from a common sense perspective, this type of design was really helpful.
Great, thank you.
I also like with the step wedge that by the end everyone's getting the intervention, so you've already put it into place, which is really fantastic for these sort of trials. I'll pose another question to you, Nicole, but I know Brett might want to chime in on this one because I wonder whether it's a little bit of a bugbear for him. One of the points raised from the editorial was around the fact that the trial began in June, which is the Australian winter. And they felt that the control data was then heavy on winter pneumonia, whilst the intervention came supposedly after the weather warmed. I guess there's what's your thoughts on that comment? And again, probably let the others have their say as well.
I was wondering if this particular comment would come up. I have given it some thought. I mean, it is possible that there is some seasonality that hasn't been accounted for. But having said that, one of the sort of the key aspects of a step wedge design in terms of both the design of the trial itself and the analytics that we use, we account for temporal trends across the trial course. So the idea, we typically call these trends secular trends. So anything that happens over the course of the trial that isn't directly related to the intervention itself. So this is part of standard techniques that we use to analyze cluster RCTs. So in a sense, so that secular trend, I guess, in our case, could be a combination of seasonality effects, if they were there in this particular trial, but also other background variation that might be attributed to changes in the hospital or at the ward level over the course of the trial. So in terms of that analysis itself within the paper, it's sort of buried right in the back. But we do map out those temporal trends that have been estimated in the analysis, and you do see variation from month to month. So to what extent that variation is purely due to seasonality, we can't say definitively, but it's most likely a combination of some other background effects and seasonality if it existed.
And I'll let Martin chat about seasonality, but I guess my other add to that would be that there was a delay in Hospital 3 commencing the trial. So in fact, they spent their 3 wards were in the intervention period. The last intervention period. All 3 wards were in the intervention, and that was during the entirety of winter, June, July, and August. So you could almost argue the opposite in terms of the design, that there was a fair chunk of wards in the middle of winter during the intervention period. So I think overall it was probably well balanced out. And I'll throw to Martin about the seasonality and whether it exists side of things.
Yeah, I mean, I think it's a really good point, but I just don't think anybody knows because there are no data. So if you go searching for it, you find absolutely nothing. And I go back to Diane Baker's done some really nice work. I mean, I know it's retrospective review, but all of her work going back over periods of years of looking at onset of hospital-acquired pneumonia, seasonality is never mentioned at all. So they either didn't look or they just didn't pick anything up looking at their data. Maybe it would be interesting for them to focus on that and actually go back. I mean, that's looking at case note reviews retrospectively, that's subject to coding biases, that sort of stuff. But I've never seen any study mention seasonality. I think Aileen Wolfensberger's work, they did adjust for seasonality, but then without evidence of seasonality. So I think it'd be fascinating. I mean, clearly there's seasonality in community-acquired pneumonia, but I'm not sure about hospital onset pneumonia because everybody's in fairly much the same condition annually, you know. So it would be fascinating to look, but I'm not sure that it's a thing.
I could have a follow-up question about more whether when you start these trials and then you have delays, you tear your hair out and you're like, oh, this is so annoying. But was that hospital delay actually sort of a secret win or something that actually turned out to be a bit of a blessing in disguise?
Oh, it could be now that the issue of seasonality, I mean, it could be. And that is one of the challenges of this step wedge design is if you had major delays. It wasn't a major delay. It was I think 6 weeks behind the other hospitals. So, you know, logistically, that's what can happen. I guess one of the risks of step wedge designs is if a hospital pulls out, then I think that would be a statistician nightmare. But we didn't have that. So yeah, it could have been
Nicole's getting a twitch over there.
How would you deal with that one then, Nicole?
Hypothetically speaking. No, you don't need to do that.
It was so impressive to see the 60% reduction in pneumonia. I think that's just so amazing. But I was particularly intrigued that that difference wasn't observed for lower or upper respiratory tract infections. And do you have any thoughts or any theories as to why you might not have seen as much of an impact on those conditions?
Yeah, it's a good question, and I think the 60% probably also. Well, I guess it was a bit of a surprise in terms of the reduction. But at the same time, it's consistent with other studies in conducted in aged care and another cluster RCT done in the US. So it was very comparable, which I guess in some ways reassuring. But yeah, we wanted to look at these extra secondary outcomes. I guess one of the fears we had about why we didn't see reductions in upper and lower respiratory tract infection was possibly that these are going to be more viral, caused by viruses more than bacteria, where bacteria is probably going to be the main focus of our intervention. So that was one sort of working hypothesis as to why we didn't see that. And the definition we use, the ECDC definition we use for NV-HAP, doesn't require a big onus on microbiological data, so you can rely on signs and symptoms and a physician diagnosis. And whilst that comes with problems, of course, it comes with the advantage, it's consistency over the entire study, but it does mean that you don't have a lot of micro data to rely on. So that was one of the things we couldn't really get into in terms of trying to understand that a little bit more. But I guess that's sort of our running hypothesis. I was probably a little surprised we didn't see some reductions in EENT infections, because I kind of thought if we're doing something to do with the mouth, maybe we'll see some benefits with reduction in sort of oral thrush and those kinds of things. But we didn't see that. So that was, for me, a little surprising. But again, the problem with the EENT definition when using CDC definitions is it's heavily reliant on certain criteria. And so one of those can be if a physician has prescribed nystatin and they really have just one other symptom, they're going to be having an EENT infection. So if you enroll a ward that's got a high proportion of people who might be on nystatin because that's the prescribing practice or because it's the type of patients that are at risk, immunocompromised patients, then you're going to see a lot more infections of those anyway. And which is actually what we saw in one of the hospitals. I think there's quite a fair few more EENT infections in one hospital compared to the others. So perhaps that's why we didn't see reductions in that infection.
I'm going to ask a few questions now about implementation, because that's my absolute joy in life is implementation. So Martin, the first question is for you. The intervention used research nurses for 20 hours a week. Some people might suggest that the success might actually be related to having those research nurses hanging around, watching, recording, and just the extra vigilance associated with knowing that that is going on, having extra experts on the ward and those sorts of things, rather than the actual biological effect of the oral care. How did you separate the two, and do you think that played a part?
I mean, human behaviour always changes when people are watching us, as we know, having done hand hygiene audits and getting 300% compliance as opposed to when no one's watching. So that possibly helped the actual making sure people did the oral hygiene. But for me, the mechanics of it are, if you're keeping people's teeth clean, then you're going to prevent microaspiration. So however you manage to get that done, I think that's all right, to be honest, because I can't imagine any hospital doesn't have in their policy that patients should have their teeth cleaned twice a day. So this is just supporting people with information to help them understand why this is important, rather than it's just in the policy. I always find people do things better if they understand why. And we knew from previous work that the connection between mouth hygiene and pneumonia hadn't been made by many people, by nurses, but also clearly by patients as well. So I'm not sure that standing there observing, and I like to think that these people were not standing there with a clipboard just ticking off when that wasn't the purpose of them. They were there to support and educate and help people understand why oral hygiene was important. So it's however you manage to improve the standard to actually get to where you should be anyway. I think that was my view of it. What do you think, Brett?
Yeah, I tend to agree. So our research nurses, saw the new patients admitted to those wards and provided them with a pack and information and why oral care is important and the toothbrush. I actually think that's probably one of the most powerful parts, is actually just having access to a toothbrush and toothpaste and knowing that it's important to brush your teeth in hospital. I actually think it's probably as simple as that. And having access to just-in-time resources when you're not sure what to do, both from a patient point of view and from a clinician nurse point of view, when you were unsure about what am I meant to do with this person who's got this type of mouth or condition. So I actually think it's probably largely to do with that. And even if I think, this wasn't an implementation-based RCT. There's clearly implementations throughout its entire design with the way it's phased, but I think it would be an interesting piece to see, even if you just give people a bit of information, a toothbrush, how much benefit would you get out of it? And I suspect you'd probably get a reasonable amount. And equally for nurses, as Martin alluded to, they just really were not aware of the importance of oral care as it relates to infection prevention. And I think just even being aware of that can help change practice, as most things do with so everyone do the right thing.
And I think there's the simple messaging, use me to prevent pneumonia on the toothbrush, is quite powerful, actually. So for the patient, they're reading it on there. Actually, this is something simple I might be able to do to help myself. So I agree with you. Giving that pack out probably had a very big impact on those who are able to perform oral hygiene themselves.
Interesting. I had a text message from one of the ID physicians at one of the hospitals, and he said, I just want to give you some more feedback. And this was only probably a couple of weeks ago. So the trial had finished there, I don't know, 8 months ago. And the oral compliance of oral hygiene has still continued to increase. And some of the comments on the ward were really positive. And so, and thanking us for being one of the sites. So I think it's had that, again, they're one of those things with the step wedge design, it sort of helps leave that residual effect afterwards, which was pleasing to see. And so even if that was the intervention, we're still seeing the effect 8 months later. We're still seeing, 75% oral hygiene being performed, which is about as high as it was in our trial. So that was really, really amazing to see.
That is amazing.
Can I jump in and ask a follow-up question? Sorry, Sally.
No, you're right.
Do you think, because you did some fantastic consumer co-design work and really worked closely with your consumer cohort, do you think that's part of the reason why you've seen that sustained impact, or is it more than, are there other things that you think really led to that success?
I think it had a big part to it. I mean, so the phase one of the trial before the RCT, we did surveys, we did focus groups with nursing groups, and then we also did work with patients. And the things that Martin mentioned earlier all became really clear. People didn't have access to toothbrushes. They didn't understand why it was important. Patients didn't know, and some of our consumers would say, if someone just told me I was brushing my teeth in hospital, I would brush my teeth in hospital if I was going to get a benefit from it. And as I say, they came up with the wording for what should be put on a toothbrush to help prompt them. So I think that engagement piece was absolutely critical in the success. And it was kind of like the massaging of the intervention. We had the idea of the intervention, but how to really get that best implemented was helped by doing that work and hearing from them afterwards. And in fact, the website which Martin designed, which includes all the resources, we've gone back to our consumer group and they're currently reviewing it now, thinking about better ways to improve it. They've come up with better wording for future toothbrushes. They've come up with a better design for a bag. And so, all this sort of stuff, you're getting some fantastic ideas from them. So I think that'll help. And we plan to make all these sort of things open source later this year available for people.
I think that's fantastic.
It leads to my next question, Brett, actually, which I was going to direct to you. So I've already had a number of my sites email me a PDF of the study of publication and say, we want to do this. What do we need to do? So that's exciting for people if they're going to be able to access those resources. I guess one of the things that I'm always conscious of with that is that our workload is always already very high if we're talking for everyone involved. If a hospital can't afford dedicated research nurses to do that sort of groundwork, what would be your advice to people who want to go ahead and do put in the intervention without that sort of focused, targeted resource to support them?
Yeah, I think the easiest way will be to provide toothbrushes and information to patients when they get to a ward. I don't think A&E or various areas are the right place to do it because those will either go home or they will they've got too much information at that point in time. They're absorbing a lot. They're sick. They're absorbing a lot of information. And so what I think that would be the simple thing, and what Martin and myself and others are working on is currently being worked up as a new website, and on there will be where you can download bags, we can order those bags from, and knowing that they've been tied and tested and had consumer involvement, there will be where you can get toothbrushes from, the type of branding that you can get on them. And there'll be PowerPoint presentations for different groups. There'll be information for consumers, and there'll be training resources for nurses. And so all this stuff will be readily available. So all this stuff's ready to go. And I think we'll be ready to go by the end of the year. And we're launching that at the ASIPSI conference. And I think that's as simple as that, really. I think having something where people, as a patient coming into a ward, getting information, toothbrush, and saying this is why it's important, even as a nurse is, inducting the patient on the ward and doing their admission information, just having that 10-second conversation that says, if you brush your teeth whilst you're in hospital, you can reduce the risk of a really common infection. And here's a toothbrush. And if you have any trouble brushing your teeth, give us a buzz. And similarly, it's a message for visitors coming into, they can also help their loved one brush their teeth as well, help them get to the bathroom if they can't. So I think really simple messaging like that would be, we wouldn't cost any resources, or very, very, very little, about $1.50 for a toothbrush.
Fantastic. Thank you.
My turn now. So I might ask Nicole a question. Was there anything in the conduct of the trial or the data that really genuinely surprised you from when you were involved in the running and then also the analysis of the trial?
That's a good question. I think I'll call out the obvious and say I was quite surprised by the effect size of the intervention. It's one of those things as a statistician, when you see the result for the first time, your immediate thought is this correct? And you sort of go about and you do your stress testing and try and convince yourself otherwise. And having worked with Brett for many years, he knows sort of the process that I go through. But yeah, I was very surprised that quite a simple intervention was that effective.
Fabulous. Yes, I noticed that you did multiple sensitivity analyses, so I assume that's part of the usual process.
Yeah, that's right. All the supplementary material that only the statisticians read.
I had to delve into it. I like the picture of the three-sided toothbrush. That was fascinating in itself.
I think Brett has to take credit for that, right?
Yeah, it was funny. We had dentists and oral health specialists on the team as well. The dentist came up with the idea of that, and they said, "What about for time-poor nurses, where they're maybe not going to do a great job? They could clean three sides of the tooth in one brush." But I tell you what, the patients didn't like them very much, and neither did the nursing staff. They're actually quite hard to use. They feel weird on your mouth, but it was a good idea. It's worth trying these things.
I do have a question, Martin, for you. This is very similar to actually when we talked about the clean trial. So we saw documentation of oral care jumped up to 62%, 61.9%. Is your feeling, and I think this links back to the question before, and I have my own view on this as well. Do you think that the care was better, or did they just get better at writing it down because they knew they were being observed? Or do you genuinely think that wasn't happening beforehand, which is concerning in itself. But my personal view is that it just wasn't happening. Because if I think about how shocked people are when I suggest that we should clean patients' hands after they go to the toilet, which to me is just a general basic thing for everybody all the time, it wouldn't surprise me if people aren't getting their teeth cleaned. And that oral care wasn't being done. But do you truly believe that that was what happened, that it was a change in the actual practices and it was just a documentation of that?
Yeah, first, you mentioned the toilet. You haven't been in the gents recently, have you? It's not quite the same
I tend not to go into those.
No, I actually
can
do think
avoid
it was I actually do think it was genuine,
Yeah.
mainly because if people had told us beforehand, oh yeah, we know that oral hygiene affects pneumonia, then I would think, all right, maybe they just weren't writing it down because they think, well, we were doing this anyway.
Yeah.
I mean, so I genuinely think that they were not writing it down because it wasn't being done. And we saw, and I think there are many studies now looking at the qualitative discussions where people just don't prioritize it. It drops down the list. We don't have time. Oral hygiene drops off. I mean, in the UK, the registered nurses probably wouldn't be doing that anyway. It would be the associate nurses or the healthcare assistants who would be doing daily personal care, and they probably wouldn't know that either. So I genuinely think that they were documenting it because they'd done it. I mean, they will definitely have known by that stage this is important, but I can't imagine why people would document oral hygiene if they hadn't done it to make themselves look better. I just can't imagine that at all. So I genuinely think that was a change, a step change, and that's probably what's mirrored the results. As being so good,
profound. Yeah.
I think there was no incentive for them to lie on documentation.
Yeah.
No, it was anonymized, wasn't it? So it's not as if they personally would gain prestige through documenting more.
That's right. You know, the oral care feedback was provided at a high level to the research nurses. It was never at an individual level. So no one's ever worried about, oh, someone's looking at my practice. So I don't think there would have been incentive. And I guess the other thing would be there are other ways to do it. Like you could directly observe oral hygiene, or you could, which would be subject to Hawthorne effect, just like, you know, hand hygiene compliance. Or you could ask patients or nurses, did they receive or do oral care today? But that's just going to have a different desirability bias associated with it. So I think it's still probably one of the only ways to do it without introducing or being worried about other types of bias.
I think too, it was more around that. Did we just think that it was being done, but not documented, which, you know, we do know happens on occasion, but generally across the board is if it's not written down, like we know with, although there are a lot of devices that are inserted that apparently were never inserted that magically appeared on people because they had not documented the insertion at all. So I guess it does happen. But yeah, whether you felt like it was happening and just not documented and now they're documenting it, or whether, it just was a genuine, okay, now we're aware of it and we're actually going to document to actually make sure it's happening. And I tend to agree with Martin. I think it's a genuine change in practice based on the results.
So, Nicole, in the paper, you analyse the data at both the patient and the cluster level. And for those of us who aren't particularly statistical wizards, can you explain why did we need to do both views for this trial? And does one of them tell a truer story of how well the toothbrush has worked?
Sure. I think I'll preempt this to say this was a very lengthy discussion amongst myself, Brett, Alan, Andrew, and a few others. We kind of tormented over this decision for many months, I believe, before we finalised everything. I guess in terms of does one give more a clearer picture than the other, I think they're just two different ways of looking at the data and interpreting the data to the same end. So in terms of the patient level analysis, one of those sort of the key strengths of the data collection for the HAPPEN trial is that we did have individual level data, given it was an individual level intervention. And we had information on both the timing of admission to the trial ward and the timing of the infection as well. And that's quite often something that we don't get in standardized data collection, is that timing of infection. So with that, we were able to look at the risk of acquiring HAP at an NV-HAP, I should say, at the patient level, also accounting for that time-dependent exposure as well, knowing that some patients might only be there for a few days, whereas others might be in the ward for a couple of weeks. So sort of as part of this robust discussion, I'll call it that, quite often what we see in other published trials in IPC is that we're reporting incidents, say, per 100 admissions or per 100 admission days. So very much that sort of ward level or cluster level in our case. So the results from both analyses pointed to the same estimates of effectiveness. They were just, at the end of the day, different ways of reporting the same data because people are familiar with different interpretations. But yes, you're right. It was part of those many sensitivity analyses and looking at the data in different ways to be sure that, we'd struck on something that was effective.
I thought I'd just quickly ask a question as sort of the final word, and it's always something I reflect on as a clinical trialist myself. I mean, to all of you, what was the standout thing that made the trial such a success? Or conversely, if you were to do it again, or do something along the same lines, what would you do differently?
Do you want to go first, Nicole?
Yes, I'm thinking.
All right, well, Martin, do you want to go first?
No, I'm still thinking as well. I think relief at getting this study done, getting a really good study done and getting it through review and for Brett and co to get it into a good journal and to see an absolutely rammed room at ESMID Global of people going along and to see that this study on what should be fundamental nursing care get picked up by news outlets straight away, and for Brett to be inundated with people wanting to talk to him about it, and for it to be featured as a news item in New Scientist, and yet this should be embedded in normal everyday care. To me, it's a relief that it shows that good nursing has such a good impact, such a fantastic impact. So that's my overwhelming feeling of this, really.
I think for me, stepping away from my comfort zone of numbers just for a second, I'll make an exception. I think the biggest part of this trial success, going back to earlier comments, was the consumer engagement piece. It's something as researchers in Australia and sort of everywhere else at the moment is the importance of consumer input and engagement from the very start of any research study. And I think the fact that there was very meaningful engagement to design the intervention and how it would be delivered was a key to success for this trial. Even just the wording on the toothbrush, that meant something to the patients. So I think that was the most rewarding part of being involved in this trial, is seeing that consumer involvement in action.
I think mine's almost a combination of Martin's and Nicole's, to be honest. I mean, they're doing the trial, actually getting it done was just a relief because we've been talking this topic up for a long time, and then we had to execute. So, and for me, right back to the ethics application where you really don't know whether an ethics committee is going to approve waivers of consent, and the whole thing could fall over at that point in time. So that was like the first hurdle. And I think I agree that the consumer and engagement piece, I think having a really multidisciplinary approach and team helped. So, we had oral care specialists, we had, dentists, we had nurses, educationalists, digital people in digital technology, infectious disease, microbiology, IPC, statisticians, health economists, and so on and on it went. And I think probably the most rewarding thing out of all this is also seeing the huge capacity building that this has led to. We've had several ECRs, early career researchers, on the team. We've given them the opportunity to lead papers in their own right, and they've done that really well. And there's more to come from that. There's about 3 more papers, I think, still to come for this project. And so for me, that's actually been the rewarding part, not just the result and the engagement, but seeing the team and just take this on and lead different parts. They were just a fantastic group. So and that includes the consumers involved in that. So and the professional organizations, we couldn't have done that without that. And ASIPSI really has really led the way, I think, in how future research can be done well with professional associations, and particularly the piece that's going to come to follow. And I think that's the exciting part, because we can learn a lot from that and go, how can we do that better for more trials in the future? So I think it's all the other peripheral stuff as well as the results that have been really pleasing for me.
Can I ask a little follow-up question with that? The feedback that you've gotten, you mentioned you had a ID physician get in touch and say how well it's continued on. During the change period, did you have much feedback about the intervention? Like, just to take Martin's point about it being fundamental, foundational, basic, what we would consider basic nursing care, was it that hard for people to integrate into their practice? Did you get a lot of pushback? Did you have an opportunity, or did you get feedback from the research nurses about the difficulties around it? Because they're the types of questions we will get when we try to change practice. But I think it's one of those really easy interventions that can make such a difference.
It's a great question. Yeah, we did. I mean, we got regular feedback from our research nurses because we have multiple part-time ones in different sites, and so we got regular feedback from them on what they were experiencing. And you see all the highs and lows that you would do with human behavior. So 95% of the time things go well, and then there's other times where it doesn't. And just like we experienced in phase 1, where we had some nurses in a focus group saying, I don't believe that oral care is important, or I don't believe that oral care and the provision of that is a nurse's job. And so I was shocked by some of those comments that came up, but they were still some of the things that came up in real life in the trial, in very small proportions. So because you'd done the previous work, you could kind of almost know how to respond to that and not worry about those scenarios. You're not going to probably change those people. Overwhelmingly, people engaged, and I think for patients absolutely so. And there were some patients like clinicians who also would say, well, I don't brush my teeth at home, so I'm not going to brush it in hospital. I don't care. And that's fine. That's their choice, right? This is why it's
okay.
dramatic as well. Yeah.
It's not okay. I'm not telling my children that, because I'm using this at home every day now. When they ask me why I make them do it twice a day, I'll say, well, I'll give you Brett's number. He can let you know.
And I think the nurses on the wards, one of the things that the research nurses were reporting was that once they had an idea of how this could actually improve and potentially reduce the risk of infection, they were really on board. And actually, I think probably felt good that this part of their nursing practice can actually do something really valuable for someone that probably hasn't been that much of a focal point in the past. So overwhelmingly good, but like everything, you get the ups and downs.
I just got a little comment. You asked if would be anything you'd do differently. I would have been interested to see if there was any impact on antibiotic prescribing, and did we reduce the tonnage of antibiotics going through these departments? And that's not something I don't think we looked at. But to me, that's a big impact as well, because anything we can do to reduce prescribing has got to be a good thing. And if any of those organisations, if you did it in an organisation with a C. diff issue, would it have an impact there? Because there have been some quasi-experimental work done over here in the UK where people have put in dental nurses for periods and dropped their pneumonias, and their C. diffs have dropped as well. But I'm also interested in the chain of infections that leads people to an endpoint like a C. diff infection. So I think there's an opportunity to do some work there as well.
Yeah, I think it would have been a good secondary outcome in hindsight. And I would say, Sal, just going back to your other question too, we have conducted interviews with nurses and our research nurses and patients involved in the trial. And that's under review at the moment with the journal. So that will be out there in terms of all the experiences from those 3 perspectives about their experience and perspectives of the trial.
Fantastic. Well, I think that's about it, isn't it, Trisha? I think we've given them a run for their money.
Long enough.
Well, thank you so much. Thank you, Trisha, for being my co-host today, guest co-host. And thank you so much, Brett, Martin and Nicole, for the opportunity to talk to you about this really amazing trial. As you've said, Brett, it is a really good example of the type of research that we can do. I know we were thrilled through ASITSI to support it and be part of it. And, we're really excited to be able to contribute by interviewing you all tonight. And, you know, we look forward to hearing more and more about it over the next few months and up to conference as well. Thank you for the invitation.
Thank you. I think I'm off to clean my teeth now.
Yeah, it made my teeth feel made me feel like I want to go clean them. It's like when people start talking about having nits, you start scratching your head.
That's right. Oh, thanks, Sal. Thanks, Trish.
Thanks
Thanks very much. Thank you.
Thank
Pleasure.
you.
See you.